Thank you very much for that introduction. I'm saying in advance, I'm going to get into so much trouble with Professor Sullivan because one, I'm going to talk about all my own research, so it's very about me. I don't have any planets, and I'm going to get the app out. So, but if I can get it to pass the pub test, then I figure I'm almost there. So my title is Aging Challenges, Opportunities and Innovations, but contradictorily, I would pose that to misquote Maurice Chevalier, I would say that aging isn't so terrible when you consider the alternatives. Indeed, we should look at aging as a success story when 1 in 7 Australians are over the age of 65. That makes 93% of those living successfully in the community. But frailty and comorbidities are problems that do increase with chronological age. And this is what skews the presentations that I see in my practice as a full-time geriatrician and physician at the Prince Charles Hospital. So I tend to see those patients who have those high burden of morbidity and frailty. By frailty, I mean the definition as per Ken Rockwood, which is that of deficit accumulation. That is, the more things you have wrong with you, the more frail you are. So originally, I was curious to find out how these patients, these older, frailer patients, fared in hospital. So we tried to look at this in a cohort study of patients over the age of 75. This was back in the day when I was in the UK, and this is data originally collected by Susan White. And we did follow-up of these patients who came into hospital over a 5-year period. And indeed, we saw that the fitter patients, which are represented in the blue line on this survival curve, did okay. They lived at least 1,000 days after their sentinel admission to hospital, which was quite pleasing. And intuitively, too, the frail patients seemed to do worse. So that seemed to be it. But when we teased it out, we saw that really it was delirium that seemed to be the driving force for these poor outcomes. And it seemed to be that although it did matter whether you were fit or frail, really the main problem was whether you had delirium or not in hospital. So, it was very unlikely that these patients were going to be seeing 1,000 days, never mind 5 years. And indeed, it was my task at that point to follow up these patients after 5 years, these patients who'd had delirium, an episode of delirium. And unfortunately, I don't think any of them have survived. So it set in store to me, what is, what's going on? What is delirium? And I'm sure you've all encountered delirium. Hands up who's seen delirium? Yes, Claire. Yeah. Okay. And if you're in hospital, it is about 1 in 4, 1 in 5 of our patients, so a very prevalent problem. But it's quite a complex problem also. And sometimes it's easy to deal in terms of metaphors with complex problems. And so here you might have to indulge me again, because one of my side hustles is I make short films. So in that, I try and create environments that someone's going to sit down for at least a few minutes and might have a pleasurable time. It doesn't usually work, but that's the intent. Whereas if you can picture the same scenario for a patient with delirium, they have their sort of worst scary movie that they're enacting, and that's imposed upon them. And sometimes it's also the hospital services that are imposing that on them too. So then the next question was, well, what can we do to treat delirium? And being a medic, I thought, well, let's try some antipsychotics. So we got together with our psychiatry colleagues and did a randomized controlled trial of quetiapine, which, as you know, is a D2 antagonist with also some serotonergic blocking capacity. And we looked at this in a cohort of 42 patients divided into treatment and placebo. And reassuringly on the, I don't know whether I can. So this top graph, so the DRSR is a measure of delirium. So it's a delirium rating scale revised 98. And the higher the score, obviously, the more likely to have delirium, the more likely you are to have delirium, with a cutoff conveniently around about 14. And what we were seeing is that patients who had quetiapine seemed to get better faster, 85% faster to be precise, which equates to about a day, which was pleasing, but also modest. Other trials and other antipsychotics haven't been, those figures haven't necessarily been replicated with using other antipsychotics. So we set about thinking, are there any other non-pharmacological options that might help in delirium? We set up what's called a close observation unit, which is really just an enhanced environment for the patient where they had increased nursing ratios for this particular unit. We had anticipatory nursing practices, such as being very vigilant with regards to toileting and analgesia and mobility, and also had integrated in a new behavioral management chart, as you know from Fred Graham's work here. We use the Pittsburgh Agitation Scale. And with just kind of those simple measures, we found that we managed to, in terms of before and after introduction, we managed to reduce the mortality by 10%. So we were quite gratified by that. But then as the clinician, on the floor, I was thinking, well, is that the best we can do? Clearly, we've enhanced the hospital environment such that it's a more pleasing environment to be in. But is there anything else we can do? So actually, it arose from a corridor conversation with Liz Whiting, whereupon Liz happened to say, well, why can't we get patients with delirium home? Why can't we manage their delirium at home? And I said, are you crazy? So we got seed funding, we did a trial of it. And so we looked at 96 patients who are approximately evenly distributed and with a high burden of comorbidities. You can see there the clinical frailty scale is 6, meaning these patients are very dependent. They're quite poorly according to their Patchy scale. And a quarter of them hail from an aged care facility. So these are kind of representative of the patients one would see that I think we'd all see in our practice with delirium. And also half of the patients having dementia. We achieved a reduction in length of stay by 3 days. Mortality and 1 month's readmission still remained high, which is unfortunately a very recidive sort of outcome measure. But we were quite pleased by that outcome. We've now rolled it out as a standard of care. And before all the old stuff going on last year, we were looking at doing cluster randomized trials with other places. But then we were thinking, well, that was 100 patients, and that was over a year, and we get about 3,000 we get over 6,000 patients a year at Prince Charles through internal medicine. And we thought 100 patients, well, that's not right. We should be getting far more than that. We must be missing lots. So we thought, well, why don't we try and understand it better? And this is the study that I wish we'd done, but we are going to try and replicate. And this is a study by Choi and colleagues, which has looked at functional MRI. Now, if you can concentrate on these top 4 on the right-hand side, these horizontal slices through the fMRI, and the top 2 are healthy controls, and these middle 2 are patients with delirium. Now, what we're looking at here are two paired networks. Now, we're looking at what's called the default mode and a task positive network. Now, the default mode network is what some of you might be doing right now. It's what you do when you're reflective and maybe even daydreaming, okay? It's a very important thing to be doing, but when you're doing stuff, you want to be engaging a task positive states. That's thinking and planning and doing. But you can't do both at the same time, as this top fMRI would show, because what's happening here, there's a lot of activity here in your default mode network, which is places like your angular gyrus, your precuneus, and all these midline regions here. That's very active. And at the same time, the prefrontal lateral areas are switched off. So I would say that was during a reflective state, one would presume. And what's happening in delirium, and that's denoted by the orange here, is where the default mode is very active, and the blue area here is where the task positive network is switched off. What's happening in delirium is that the default mode network is switched on, but so too is the task positive network. So what's happening, instead of one bit of the brain talking and the other bit listening, they're both talking at the same time. And we thought that, could this be axiomatic to the underlying neurobiology and also the clinical characteristics of delirium? And up to now, screening tools, which there are about 23 or 24 at the last count, they look at the symptomatology of delirium, but we thought, oh, why don't we try and think about whether there's any tools we could base around the paired hub aberrancy. So we sat around with a group of multi-professional colleagues with a vast amount of coffee and came up with a simple tool, which was think of a place that you've never been to before, which is meant to engage your default mode network, because you think of something nice. And then where would you go, which would be the executive planning bit of it. And if you can answer it congruently, then you're not delirious. And when we applied this, so one of our advanced trainees, Stella Lynn, who got an R.M. Gibson Award for it, she tested it in 100 patients. It turns out the psychometric properties are pretty good. 83% sensitivity, 81% specificity, a negative predictive value of 97%. It even outperforms sort of standard measures. And what we're looking to do next is actually just try and plug that back into an fMRI paradigm with both Herf and Kieran Berghofer and Michael Breakspear, just to see, okay, is it doing what we think it's doing? But then we had a chat with our critical care colleagues who are saying that, they think they're underdiagnosing delirium in the critical care setting. So we thought it felt like an opportunity to carve out a new set of cognitive tools, but also fluid-based tests for patients who may not be able to respond in a narrative fashion, but as long as you can get a yes or no answer, we had to kind of work around that. So, I developed a set of 60 questions, and which are designed to test both attention and also organization of thinking. And then the idea was then we put them together as a set of 6 questions, and the system randomizes from those 60 questions, 6 questions which then you test until either completion or failure in 2 questions. If you complete the 6 questions successfully, you're not delirious. If you fail in 2, the algorithm stops and you're declared not delirious. And I'm hoping it was going to come out this weekend, but didn't quite get there. But against reference standard 2 psychiatric opinions as our sort of reference standard, we're getting a 86% sensitivity and specificity of 73% in the intensive care setting with that. And that was one of the examples, but it's quite simple, but it's is it legal to cross the road with a red light? And it's a yes, no answer. So the patient can gesture even if they can't talk. Okay, so we thought we've gone a reasonable distance then. We're trying to figure out what to do with delirium. But then what's been nagging me for a long time is that there's been a big movement to try and recognize delirium. We're indeed making a lot of strides, and I'll talk about World Delirium Day. I'm sure, did anyone hear about World Delirium Day here? 5 minutes, okay, right. So we thought we better try and figure out the cause of delirium. So Professor Sullivan might have another stern conversation afterwards. But we thought we could develop a paper-based approach. We developed an algorithm to try and identify the heterogeneous and multifactorial causes of delirium, which we then transpose into an app, which we've gone through a series of refinement, and our preliminary data shows that we're doing quite well again with sensitivity and specificity, and that's the first of its kind. You can't do these things without a team, and again, this is our partying on World Delirium Day in the obligatory yellow. But then again, who's experiencing delirium? And of course, dementia is an independent risk factor for delirium, and so we got Bupa funding and funding from the Common Good to try and identify better biological markers for dementia. So what we're doing is a suite of standard assessments using a psychological neurocognitive profiles together with imaging, including MRI and amyloid PET. So here you see the avid red and representing amyloid, positive amyloid PET scan, and this is the blues and greens of low amyloid with a amyloid negative case. So this is new data from yesterday, so it's preliminary, but this is what's called our FEOBV scan. So what this does, it binds to the presynaptic acetylcholine vesicomolar receptor transporter. So and what it does, therefore, it's a signature of what's going on in the cholinergic system, which is the heart of sentient thought. And what we see here with the eye of faith, and this is someone who doesn't have his healthy control without amyloid, who's amyloid negative. You see there's at least these greens and yellows and oranges, which are much more richer than the relative paucity of green and the blue hue here in the parietal lobes. And look, it's not just the eye of faith, there's a statistically significant difference, particularly when you look at the lateral occipital lobes. But then what happens if you get a dementia? Well, we've got an internal medicine dementia research unit, which have been undertaking trials set up by Chris Davis, and now Dr. Poulet is the director. We've been undertaking a lot of trials in Alzheimer's disease, but also recently vascular dementia, and also sort of holistic studies with GOMA in terms of art and dementia. I was PI for the Biogen study, which is aducanumab, which is a humanized monoclonal antibody against the oligomers of beta amyloid. And as you know, there's a suggestion of a dose-response effect to aducanumab, and in the subgroup analysis for the high-dose treatment, there seemed to be a reduction in cognitive decline in these patients. So this is an area of very intense scrutiny going forward and further inquiry, because this is a promising new area for Alzheimer's research. So, so just for me, in terms of my insights, as I say, I'm a full-time clinician, so this is I've just embarked on a PhD, and so I'm now finally getting some offline time to do research. But I think if you're a clinician on the ground, then your research should follow your natural inquiry. When you're seeing problems, common problems, then think about those and pursue those as lines of research inquiry. I think clinical medicine gives a great opportunity for collaboration across other disciplines. And I think the highly rewarding thing is seeing the fruits of your labor in terms of when your ideas and innovations start to be embedded into practice and improving health outcomes. Don't forget the declared conference, 8th to 10th of September. That's the National Delirium Conference, which will be happening in Brisbane at the BCEC. And follow us on Twitter. It'd be great to see you there. And thank you to all my collaborators. And I'm sorry I missed out Royal Brisbane as well with Sarah Ward and Alice Greenwood. Thank you.